Bismillah ar-Rahman ar-Rahim. We will move to the next section. And nowadays we are speaking, we heard several times in this conference about the cardio-renal metabolic syndrome. We are viewing now the diabetes, type 2 diabetes, as a cardio-renal metabolic syndrome. So there is always an interaction between the diabetologist and cardiologist. We know that type 2 diabetes is associated with atherosclerotic cardiovascular disease, is associated with heart failure, and is associated with atrial fibrillation. So Professor Nabil will discuss the talk or the inter-talk between the diabetologist and the cardiologist. تفضل يا دكتور نبيل.
بسم الله الرحمن الرحيم. في البداية طبعا بنرحب بحضراتكم، كل سنة وانتم طيبين بمناسبة حلول شهر رمضان وبمناسبة الأعياد. بشكر الأستاذ الدكتور صلاح شلباية على المجهود اللي عمله الحقيقة في تأسيس الدي جي اي اس، وده اكتيفيتي بين الدايا ايجيبت والاي اس دي. بشكرك يا دكتور صلاح، ودايما في عطاء ودايما في تقدم بإذن الله. My topic today is diabetology and cardiology in dialogue. We all have the idea about that we are in the era of the cardiometabolic meetings and cardiometabolic interactions, as said by Professor Hisham El-Gayyar. The large randomized cardiovascular outcome trial of the new drugs illustrate the benefits beyond the glycemic control and the microvascular complication. We all know that the hyperglycemia control is associated with improvement of the microvascular complication, but this cardiovascular outcome trials proved the benefits beyond the microvascular complication and the glycemic control in the form of the improvement of the macrovascular complication, MACEs, renal outcome, and the atherosclerotic cardiovascular disease. This cardiovascular outcome trial changed the guidelines to put the GLP-1 receptor agonist and the SGLT2 inhibitors in the first step for control of the type 2 diabetes beyond the or whatever the hemoglobin A1C baseline or whatever the target is put. This is the Capture cross-sectional study. This is the primary objective of this study was to estimate the prevalence of established atherosclerotic cardiovascular disease in type 2 diabetic patients across 13 countries, and these eligible people attending a single routine visit in the primary and the specialist care. There also a post hoc analysis exploring the difference between different countries and according to the age, gender, and the clinical parameters. This illustrates that about 1/3 of all people with type 2 diabetes have established atherosclerotic cardiovascular disease, and only 1/4 of these people treated with glucose-lowering drugs with proven cardiovascular benefits. Unfortunately, also, none of the SGLT2 inhibitors individually is being used in more than 10% of the population. And also the GLP-1 receptor agonists are also 10% of the population only receiving GLP-1 receptor agonists. So we are far beyond the control of this atherosclerotic cardiovascular disease in type 2 diabetic patient. And this is the resume of the cardiovascular outcome trial and the new diabetic drugs. SGLT2 inhibitors and GLP-1 receptor agonists. SGLT2 EMPA-REG improve the MACE, cardiovascular death, hospitalization of heart failure, and all-cause mortality. Canagliflozin and the Canavas improve the MACE and hospitalization of heart failure. Declare or the dapagliflozin improve the hospitalization of heart failure only. GLP-1 receptor agonist, there is a leader trial. Liraglutide improved MACE, cardiovascular death, and all-cause mortality. Semaglutide, SUSTAIN 6, improving the MACE, the non-fatal stroke and non-fatal MI. Pioneer improved the all-cause mortality using the oral semaglutide, and Rewind study using dulaglutide improved the MACE and non-fatal stroke. This is a resume of the results of the cardiovascular outcome and the new diabetic drugs. When they do a meta-analysis of the SGLT2 inhibitors, they found that there is a reduction of the MACE by about 11%. Cardiovascular death, hospitalization of the heart failure is reduced by 23%, and the progression of the renal disease reduced by the 45%. All were significant. As regards the GLP-1 receptor agonist, the meta-analysis of the trials of the GLP-1 receptor agonist using the Alexa, Leader, Sustain 6, Excel, Rewind, and Pioneer 6, all these proved that the MACE is improved by 12%. Individually, the cardiovascular death is improved by 12%, the non-fatal and fatal stroke improved by 16%, fatal and non-fatal myocardial infarction improved by 11%, and they all individually together and individually each has a significant results in the reduction. So these guidelines are changed by these data and by this cardiovascular outcome trial. The ESC guidelines, European guidelines, stated that in the naive type 2 diabetic patient who have atherosclerotic cardiovascular disease or patients with high risk or high cardiovascular risk, you should begin with SGLT2 inhibitors or GLP-1 receptor agonist even before metformin. And if you didn't reach the target, you then add metformin or other drugs. While in the patients who have no atherosclerotic cardiovascular disease or at moderate risk, less than high risk, you begin with metformin and then you add any of the 4 drugs if you don't reach the hemoglobin A1C target. DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2, or TZDs. This is the ESC guideline, while the ADA guideline is different in being that it intensifies first the lifestyle modification. You should begin with metformin first if there is no contraindication or not tolerated by the patient. And then if the patient is at high risk or very high risk or atherosclerotic cardiovascular disease, you add the SGLT2 inhibitors or or GLP-1 receptor agonist. And they prefer GLP-1 receptor agonist if the patient is atherosclerotic cardiovascular disease predominant, while if the patient has a high prone for heart failure or CKD, we prefer to give the SGLT2 inhibitors and then add the other molecule if there is no control of the blood glucose. Or if the renal estimated glomerular filtration rate is less than 45 milli per minute, we shift to the GLP-1 receptor agonist that can be used in glomerular filtration rate down to 15 milli per minute. How to define the risk? This is the risk stratification according to the ESC Guidelines 2019. The very high risk, any diabetic patient with atherosclerotic cardiovascular disease, or diabetic patient with target organ damage as microalbuminuria, left ventricular hypertrophy, whatever, and diabetic with 3 or more cardiovascular risk factor, or type 1 diabetes with long duration more than 20 years. This is a very high risk. High risk, diabetic per se is a high risk with duration more than 10 years without target organ damage or with plus any other additional risk factor. The moderate risk is the younger patient with type 1 diabetes less than 35 years and type 2 less than 15 years, or diabetes duration less than 10 years without risk factor. This is the moderate risk. This is the risk stratification, and according to the risk stratification, the ADA and ESD stated their guideline. So any patient above the age of 18 years old with type 2 diabetes and has one of the following, either atherosclerotic cardiovascular disease, heart failure, CKD, or at high risk for atherosclerotic cardiovascular disease, you should first intensify the lifestyle modification. You should control the blood pressure, control dyslipidemia, and give antiplatelet therapy. Plus, you recommend one of these two molecules, either GLP-1 receptor agonist or the SGLT2 inhibitors, according to the situation, what is the atherosclerotic cardiovascular disease or CKD and heart failure. Cardiorenal, CKD, heart failure, we prefer SGLT2 inhibitors. Atherosclerotic cardiovascular disease, including the stroke, we برضه prefer GLP-1 receptor agonist. This is the mechanism of action of GLP-1 receptor agonist on the pancreas. It improve insulin secretion, suppress the glucagon in a glucose-dependent manner, improve the beta cell function, decrease apoptosis, decrease coagulation, decrease the gastric emptying and decrease the postprandial lipidemia, improve the inflammation, decrease the body weight, the blood pressure, and improve the increase natriuresis and diuresis. In addition to the cardio protection on the heart. This is the mode of action of the GLP-1 receptor agonist. SGLT2 inhibitors, by inducing glucosuria and natriuresis, they improve the cardiac function, preload, afterload, and improve the cardiometabolic efficacy, decrease arrhythmia, improve the arterial wall and structure function, decrease the glomerular pressure and albuminuria that will be reflected on the cardiovascular and renal outcome to decrease the cardiovascular death, hospitalization of heart failure, and decrease the renal events. So the difference between the two classes, SGLT2 inhibitors almost diuretic-like, predominantly hemodynamic, de-stressing the nephrons and reducing the cardiac stress, while the GLP-1 receptor class stimulate the insulin secretion, suppressing glucagon, and they have effect related to the inflammation, endothelial dysfunction, vasculature, and reducing ischemia, reperfusion, injury. This is the difference between both. As regards the side effect, the main side effect of the SGLT2 is the diabetic ketoacidosis, and this can occur at a lower level than the expected, and should be taken cautiously in the periods of illness and the dehydration that increase the risk. You should educate your patient and stop this medication during acute illness or prior to the surgery. ويعني أهم حاجة دلوقتي في البيريد اوف كورونا اللي احنا فيها أو الكوفيد 19 طبعا لو patient ماشي على SGLT2 you should stop this medication. The most common side effect is the genitourinary tract infection, either genital mycotic infection and bacterial urinary tract infection. It is treated by simple measures, but if this recurs 2 to 3 times, you should stop the medication, and you didn't give or you don't give the SGLT2 inhibitors in the glomerular filtration rate less than 45 milli per minute. مش عشان حاجة أكتر من إن هي مش هتشتغل، لأن هي mainly inducing جلوكوزوريا، فبالتالي اقل من 45 مش هيبقى لها مود اوف اكشن. GLP-1 receptor agonist mainly السايد افكت بتاعها في gastrointestinal side effect, treated by start low and titrate slowly to the maximum tolerated dose. Educate your patient to take small meals, eat slowly, and stop before feeling full. It is rarely associated with hypoglycemia, but if this the GLP-1 receptor agonist given with the sulfonylureas or insulin, you should decrease the dose of insulin and sulfonylureas from 30 to 50% of the total dose. The option to give the SGLT2 inhibitors and GLP-1 receptor agonist together with each other is very important and is very beneficial option because of the synergistic effect of the both drugs on the body weight, on the ischemic cardiovascular effect, and on the muscle glucose uptake. While there is a complementary mode of action in the heart failure events, for example, in the insulin level, in the glucagon secretion, in the hepatic glucose production, in the renal protection, all over. So the addition of the SGLT2 inhibitors with GLP-1 is very beneficial in certain situations. The beginning of the action of the SGLT2 and GLP-1, it was found that SGLT2 inhibitors, the curve would be separated from within a few months, and this is have several question marks. And the GLP-1 receptor agonist begin after 1 year, which this is coincide or consistent with the anti-atherosclerotic effect of the GLP-1. This is examples of the cases. A case of the post-MI on a standard of care including metformin, hemoglobin A1C is 7%. If this patient has impaired ejection fraction less than 40, consider SGLT2 because this is a class effect to decrease the heart failure. You should give the SGLT2 inhibitor. But if this patient is associated with preserved ejection fraction, you consider GLP-1 receptor agonist. A post-stroke patient with standard care of metformin and DPP-4 inhibitor, hemoglobin A1C 7.5. Post-stroke, we should give GLP-1 receptor agonist and especially the semaglutide. So we should stop first the DPP-4 inhibitor and give GLP-1 receptor agonist. A cardiovascular disease patient just diagnosed, newly diagnosed, type 2, standard care, and hemoglobin A1C 7.5. If the patient has a heart failure or CKD, you consider SGLT2 inhibitor, higher hemoglobin A1C, and you need more reduction for the hemoglobin A1C, we should consider GLP-1 receptor agonist. And the Pioneer 6, the future direction of the GLP-1 receptor agonist in the semaglutide once weekly and oral semaglutide in the pipelines, and they present in some countries outside Egypt, but in Egypt, I think it is within a few months it will be in Egypt. The oral GLP-1 receptor agonist in practice, you should take the medication more than 30 minutes before breakfast or any other drink or oral medication, as with the injectable formulation, titrate up to minimize the gastrointestinal tracts and start slow and go slow. Mr. Chairman, dear professors and dear colleague, the recent cardiovascular outcome trials with new diabetic drugs show cardiovascular, renal, and heart failure benefits for the patients with type 2 diabetes treated with GLP-1 receptor agonist and the SGLT2 inhibitors. They have multifactorial benefits beyond the glycemic control. وده الجايد اللي قالته ان احنا بنحط الجي ال بي 1 ريسبتور اجونست والاس جي ال تي 2 انهبيتورز وات ايفر كان التارجت بتاع الهيموجلوبين A1C او الليفل اوف ذا هيموجلوبين A1C اللي انا وصلت له. Cardiology and diabetes guidelines now recommend SGLT2 inhibitors and GLP-1 receptor agonists in appropriate patients. Cardiologists, diabetologists, and GPs need to become more confident in introducing these drugs to their patients with cardiovascular disease or risk factors. زي ما قلنا في الأول مفيش أكتر من 10% فقط من البوبوليشن اللي عندهم atherosclerotic cardiovascular disease بياخدوا ال GLP-1 receptor agonist وال SGLT2 inhibitor. And thank you.
Thank you very much, Professor Kafrawy, for your clear presentation. And in facing the cardiorenal metabolic syndrome, I think there is a new subspecialty in many healthcare providers, which is called cardiometabolic subspecialty. And in order to have a harmony, a kind of harmony between us diabetologists and the internist and the nephrologist, this subspecialty is growing in many parts of the world to have what we call a cardiometabolic subspecialty. لو حد عنده يعني سؤال في الكلام اللي قاله الدكتور نبيل يتفضل. طيب أنا قلت إن هي a clear presentation. متشكرين دكتور نبيل.